Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the second episode of our discussion on adipose tissue in my YouTube channel, Medicine Made Easy. Today, we shall further understand the very important aspects of adipose tissue. And tomorrow, then the last episodes of our discussion on adipose tissue will be there. Today is a very important episodes, and what we shall be understanding the adipose tissue in more depth. So let's start. Bismillahirrahmanirrahim. Part 2 of our discussion on adipose tissue. Today's session is very important, and today we should learn adipose tissue as an inflammatory organ. This will be the first point to discuss, adipose tissue as an inflammatory organ. Then adipose tissue and insulin resistance. What's the connection between these two? Then we shall discuss the adipose tissue remodeling and fibrosis, a very important concepts and aspects when we discuss adipose tissue. Then we shall discuss the gender and age differences in the adipose tissue, followed by browning of white adipose tissue. How does it happen and when it is happened? Then we shall continue our discussion by understanding adipose tissue as a stem cell source. It's a good source, we shall discuss that. Then what's the gut adipose tissue axis? We'll briefly touch upon this. And then the pharmacologic targets in adipose tissue, followed by the role of adipose tissue in cancer. And then the adipose tissue in non-obese individual. This is very important concepts, and we shall discuss this. So the first aspects of the adipose tissue as an inflammatory organ. The key concept is that adipose tissue is not just for fat storage. It plays an active role in immune regulation. So this is the key concept. And why I say this? Because in obesity, adipose tissue secretes pro-inflammatory cytokines, tumor necrosis factor alpha, IL-6, MCP1, leading to chronic low-grade inflammation. This process is known as meta-inflammation and contributes to systemic insulin resistance, atherosclerosis, and other metabolic disorders. The adipose tissue recruits immune cells, especially macrophages, which switch from an anti-inflammatory M2 to pro-inflammatory M1 phenotypes. So this whole thing happens, and it makes adipose tissue as an inflammatory organ. Visceral fat is more pro-inflammatory than subcutaneous fat. So the one who has got huge amount of visceral fat, then the pro-inflammatory process is more happening in that very patient. So the clinical relevance of adipose tissue being as inflammatory organ is that this inflammation is a key player in metabolic syndrome, atherosclerosis, and insulin resistance. Then another aspect, the adipose tissue and insulin resistance. The key concept is that dysfunctional adipose tissue impairs glucose metabolism. When the adipose tissue becomes dysfunctional, not functioning the way it should, it impairs glucose metabolism. So if to understand this, the enlarged adipocytes in obesity become insulin resistant and release free fatty acids into the circulation. Excess free fatty acids in the circulation, it accumulates in muscle, liver, and pancreas, leading to lipotoxicity. So this process impairs insulin signaling in peripheral tissue and contributes to type 2 diabetes mellitus. So this is the whole concept. The adipokines like resistin and TNF alpha directly impair insulin receptor functions. So the dysfunctional adipose tissue, it pours a lot of free fatty acids into the circulation, which gets accumulated in muscle, liver, pancreas, leading to lipotoxicity, leading to impaired insulin signaling, and the adipokines resistant TNF alpha, they directly impair the insulin receptor functions. So the clinical relevance of these aspects of adipose tissue is that adipose dysfunction is a central pathophysiological feature of diabetes, polycystic ovarian syndrome, and muscle metabolic dysfunction associated steatotic liver disease. Then the third aspect of today's discussion is adipose tissue remodeling and fibrosis. The key concept is that the healthy expansion of adipose tissue is necessary, we know that, but not all expansion is equal. In positive energy balance, adipocytes can expand via hypertrophy or hyperplasia. Hypertrophy means increase in size. Hyperplasia means increase in number. The hypertrophy or increase in size is associated with inflammation and hypoxia, while the hyperplasia increase in number is more metabolically favorable. So excessive hypertrophy leads to hypoxia, cell death, and fibrosis due to collagen deposition. So the fibrosis makes the adipose tissue stiff and dysfunctional, reducing its capacity to store fat safely. So the clinical relevance of this aspect is that fibrotic, inflexible adipose tissue exacerbates ectopic fat deposition. So the fat starts depositing in liver and heart, and metabolic complications happens like this. The another aspect, the gender and age differences. The key concepts of this discussion is that adipose distribution varies by sex and age due to hormonal influences. And what is that? In women, they tend to have more subcutaneous fat, that is in the hips regions and in the thighs region due to estrogens, while men tend to have more visceral fat in the abdominal due to androgen dominance. Postmenopausal women, when they lose their estrogen, they experience a shift towards central or visceral adiposity. With aging, total lean mass decreases and fat mass increases, especially the visceral fat. So the clinical relevance of gender and age differences in adipose tissue is that postmenopausal women have increased cardiovascular risk due to central fat accumulation because the protective effect of estrogen is lost. So the another aspect is browning of white adipose tissue. The key concept is that white fat can become metabolically active through browning. The white adipocytes can transform into beige adipocytes, especially under cold exposure, exercise, and certain hormones, irisin and FGF21. Brown and beige adipose tissue express uncoupling protein 1, allowing fat burning to generate heat instead of ATP. So the clinical relevance of this aspect is that browning is a therapeutic target for obesity and metabolic diseases. And research is going to pharmacologically stimulate this conversion. Then the adipose tissue is a stem cell source. The key concepts: the adipose tissue contains multipotent mesenchymal stem cells, which are called adipose-derived stem cells, ADSCs. These stem cells can differentiate into osteoblasts, chondroblasts, mycocytes, and neurons. And when they are harvested via liposuction, adipose-derived stem cells are used in regenerative medicines, wound healing, ischemic limbs, cosmetic and reconstructive surgeries, and orthopedic tissue repair. So the clinical relevance of this aspect of the adipose tissue is the ADSCs are being explored in cell-based therapies and tissue engineering. Know the gut adipose tissue axis. The key concept: gut microbiota influences adipose tissue function and vice versa. Dysbiosis means microbial imbalance. It can alter energy harvest from food, leading to increased fat accumulation. Certain gut bacteria influence fat storage through short-chain fatty acids, inflammation, and bile acid metabolism. And metabolic endotoxemia from LPS promotes adipose inflammation and insulin resistance. So the clinical relevance of gut adipose tissue axis is that modulating gut microbiota through prebiotics, probiotics, dietary fibers may help control obesity and metabolic diseases. The pharmacological targets in adipose tissue, this is another aspect of our discussion today. The key concepts: modern drugs target adipose tissue pathways to manage obesity and diabetes. The GLP-1 receptor agonists like semaglutide reduce appetite, increase satiety. Thiazolidinediones activate PPAR gamma, promote adipocytes differentiation, and increase insulin sensitivity. SGLT2 inhibitors promote glucose excretion, indirectly reduce fat mass. And the new targets: UCP1 activators, beijing agents, and FGF21 analogs. So these are the potential drugs in pipeline which will target the adipose tissue to have their beneficial effects. So the clinical relevance of this aspect is that adipose targeting therapies are now central to obesity and diabetes management. Then the role of adipose tissue in cancer. The key concept: obesity is associated with adipose tissue promotion of cancer growth. So in obesity, the adipose tissue, they promotes cancer growth. The estrogen production by the adipocytes from adipose tissue increase the risk of breast cancer and endometrial cancer. And adipokines like leptin and inflammation create a pro-tumorigenic environment. The visceral obesity is associated with colorectal and pancreatic cancer. So the clinical relevance of this aspect of the adipose tissue, its role in cancer, is that adipose tissue is an emerging oncologic risk factor, especially in hormonally sensitive cancers. Then the adipose tissue in non-obese individuals. thin outside, fat inside. Normal BMI but high visceral fat. Those people who have got normal BMI but they have got high visceral fat. I had mentioned this in the intro in the first session that high BMI is a bit different from the adiposity, and normal BMI does not exclude adiposity. So here is the concepts of the thin outside TOFI and fat inside. The importance of measuring body composition is not just weight. We know that. The key concepts of thin outside, fatty inside is that some individuals have a normal weight but high visceral fat. They are called thin outside, fat inside. The TOFI phenotype appears lean but with high metabolic risk. The normal BMI but central obesity and ectopic fat in liver and pancreas. When we see their liver in the MRI, CT, their liver and pancreas has got a lot of fat. These individuals can have pre-diabetes, fatty liver, and CVD despite healthy appearance. So they appear healthy, but they're not really healthy. The clinical relevance of TOFI is that it reinforces the body composition, is more important than high BMI when assessing metabolic risk. So dear colleagues, in today's special episode, or the second episode of our discussion on adipose tissue, we discussed these different aspects: the adipose tissue as an inflammatory organ, the adipose tissue and insulin resistance, the adipose tissue remodeling and fibrosis, gender and age differences in the adipose tissue, then browning of white adipose tissue. Then we discussed adipose tissue as a stem cell source, then gut adipose tissue axis, and we touched upon the pharmacological targets in adipose tissue, role of adipose tissue in cancer, and in the last we discussed a very important aspects, the adipose tissue in non-obese individual, that is thin outside and fatty inside. So if you find this vlog is useful for you, please like, share, and subscribe to my channel, Medicine Made Easy. Coming up next is a discussion on unique aspects of adipose tissue. So please don't miss that. And after that, we shall embark on discussion on adiposity. So see you in the next vlog. Till then, take care. Khuda Hafiz.